Okay, so what we'll do, as we usually do with these types of webinars, is just give everybody an opportunity to make their way into the session. With it being online, there tends to be a few seconds just to get people in. It looks like we have a few people in now, which is absolutely fantastic. So let's get started. Hello, everyone. It's Nathan from the European Pain Federation EFIC here, and welcome to today's webinar. I'm joined by 4 speakers today who will each be providing information related to the topic of this webinar, which is, of course, in line with Endometriosis Awareness Month, which you might see on our social media platforms, and is exploring endometriosis and pain. So as you can see on your screen, I'm delighted to be joined by Jasmine Hearn from Manchester Met University, Katy, Vincent and Lydia Coxon from University of Oxford, and Marcelo de França from State University of Rio de Janeiro. Really appreciate you all being here. I'll give you an opportunity just to introduce yourselves in a second after we go over the formalities of this type of session. So welcome in. Thank you so much for being here. So today's webinar, as I mentioned, will feature presentations from our panelists. You'll be able to see those in a moment. There is, like most of the webinars that we host, a Q&A function, which you can use to ask questions throughout the webinar. No need to wait until the end to hold it in your head. Feel free to get them straight into the Q&A function, which is at the bottom of your screen when they pop into your mind, and then we'll be able to get to them at the end of the presentation. We're going to collate all of the questions and then wait until all presentations are done, and then we're gonna have a chat afterwards. This is, of course, a recorded webinar and will be available to catch at a later date on YouTube and the EFIC Academy platform, which I'm sure you're all fairly familiar with. You might also receive a link to that after the session as well via email, so keep an eye out for that one. So formalities gone. I'm going to stop talking for a little bit. So maybe we can have some introductions before the presentation. So I'll just go across everybody since we have a few panelists, which is absolutely fantastic here today, which is good stuff. So Katy, Vincent, welcome in. It's good to see you today. How are you doing?
I'm good, thank you. So yes, I'm Katy Vincent. I'm an academic gynecologist in the Nuffield Department of Women's and Reproductive Health at the University of Oxford. Clinically, my work is in chronic pelvic pain, particularly in adolescents and in those with endometriosis. And my research group focuses on pain in women very broadly, so thinking about lots of different methods of investigating that. And we have a real strong focus on endometriosis within the group.
Amazing. Fantastic. Thank you. And Lydia Coxon, welcome in.
Hi, thanks for having me. So I'm Lydia Coxon. I'm a postdoctoral researcher in the University of Oxford in the Pain in Women and Endo Care Centre groups. So my work is trying to understand pain mechanisms in chronic pelvic pain, particularly in endometriosis.
That's brilliant. Thank you, Lydia, sorry, not Linda. Thank you for that. Maybe we can go to Jasmine next. Hi, Jasmine.
Yeah, hi, thank you for having me today as well. I'm Jasmine. I'm a senior lecturer in psychology at Manchester Met University with 10 years of research background in the experiences of chronic pain across a range of different conditions, but largely sort of women's health experiences.
Brilliant. And last but certainly not least, Marcelo, welcome.
Hello, everyone. I'm Marcelo. I work as a researcher. I'm a physiotherapist, so I work as a clinician too in the endometriosis outpatient clinic at the Pedro Ernesto University Hospital, the hospital of the State University of Rio de Janeiro. So I'm really glad to be here again. Thank you.
Brilliant stuff. And everybody who might have seen the other materials on the EFIC education platform, you might see some faces that you recognize from previous talks as well, which have been absolutely fantastic. So Katy, Lydia, Jasmine and Marcelo, thank you so much for being with us today. Really, really appreciate it. So let's get started, shall we? Let's have some presentations and let's get the discussions going. So perhaps we can start with Katy and Lydia. You're presenting your materials together. Maybe we can just hand it over to you and get us going.
That's great. Thank you very much. So I'm going to start and then hand over to Lydia in the middle of the presentation. And we thought we would just start by just opening this webinar by reminding people what endometriosis is. So endometriosis is a chronic inflammatory estrogen-dependent condition. So it's characterized by the presence of tissue that looks like the endometrium, so the lining of the womb, outside of the womb. We commonly see it throughout the pelvis, often on the peritoneum, so the lining tissue of the pelvis, but can also find it on the ovaries, on the bladder, on the bowel, and sometimes further away. About 1%, for example, is found in the thorax. It's classically associated with a range of pelvic pain conditions, painful periods, dysmenorrhea, pain throughout the month, non-cyclical pain, pain with sex, dyspareunia, and also pain with bladder and bowel function. It's also associated with infertility. But the really interesting thing about it is that the relationship between the amount of disease we find when we look either with imaging or at surgery and the symptoms is fairly non-existent. So you can have really severe stage 4 endometriosis and absolutely no pain at all, or you can have really disabling pain but very mild stage 1 endometriosis. And a lot of the work that we've been doing within our group is to try to understand the similarities between endometriosis and other pelvic pain conditions and other chronic pain conditions, and think whether maybe our standard treatment strategies that really target those peripheral lesions that are in the wrong place, whether actually those treatment strategies are the right strategies when actually we know that about 50% of patients, whether they're treated with medical or surgical approaches, will still have persistent pain. And so I'm going to start by describing briefly to you the TRIP study, which was the Translational Research in Pelvic Pain study. And Lydia just showed previously the slide that acknowledges the very generous funding from the EU that funded this project and the large consortium around Europe and including a US partner as well, who were involved in this project. And so we had 5 different groups of women with pelvic pain within TRIP. We had a group of women who have endometriosis and pelvic pain. We had a group of women who have bladder pain syndrome, so pain that they perceive as arising from their bladder and at least one urological symptom and no history of endometriosis. We then had a third group who had both of these, so that's what we would call the comorbid endometriosis and bladder pain syndrome group. We then had a 4th pelvic pain group who had pain very similar, didn't perceive that coming from their bladder, didn't have any symptoms from their bladder, and did not have endometriosis when they were examined surgically. And we finally had a control group who had no pelvic pain, no bladder symptoms, and no endometriosis at all. And throughout our project, we explored the similarities and the differences between those groups. And you can see that the protocol of this project was published, so if you'd like to understand it in more detail, you can look at that. But basically, in summary, what we had was a really large set of questionnaires. We had blood, saliva, and urine, though we haven't as yet looked at the saliva and urine, for all of these participants. And then smaller groups completed additional questionnaires and did some more detailed, what we would call psychophysiological testing. So we looked at their response to a variety of painful stimuli. We looked at their heart rate during stressful sessions, for example. And then a very small group also had a neuroimaging brain scan. And we know that pelvic pain is not a single entity. It describes a variety of pelvic pain symptoms. And you can see here that actually all of our groups described painful periods, non-cyclical pain, pain with sex, and pain after sex. But the thing that was really key for the endometriosis group was that they definitely scored higher on the painful periods. And we know that that is a really common symptom of endometriosis. But we also know that endometriosis doesn't exist alone. Women are much more likely to have chronic pain in general, and they also have lots of other health conditions. And this is obviously a really busy slide, and I don't expect you to read it, but it just shows an example of how broad the comorbidities within our cohort were. But I just really wanted to focus here on our top 5 comorbidities. And obviously, these are all things that also happen in the background population. So you can see sort of up to 17% of our controls also described these. But what's really clear is that at least a quarter of our participants with either endometriosis or bladder pain syndrome were describing depression, anxiety, and migraine. We also see that asthma and IBS are very common. So these women have a variety of different things that they're dealing with on a daily basis. And though we think of endometriosis as being a pelvic pain, actually what we see is that many women describe their pain as being really widespread. So this method of classifying pain was described by the US group, the MAP consortium. thinking about whether the pain is localized just to the pelvis, or whether it spreads 1 or 2 regions outside of the pelvis, or whether it spreads really widely, so sort of 3 to 7 regions outside the pelvis, what we would call a widespread pain. And what we can see is that it doesn't matter what your underlying diagnosis was. We found that the groups were fairly spread between those who described having pain localized to their pelvis, those who had really widespread pain, or those that were a bit more intermediate. But I think it's clear that within the widespread group, so the group with 3 to 7 regions, endometriosis is really overrepresented. So it seems like endometriosis is commonly associated with pain outside of the pelvis as well. And we know that all chronic pain conditions have an impact on quality of life. And so it wasn't surprising at all that what we saw in our study was that all the women with pelvic pain described an impact on their quality of life. But I think what we were particularly struck by was those women who are dealing both with endometriosis associated pain, but also pain and symptoms arising from their bladder. So that comorbid group were particularly badly impacted in terms of both their physical and their psychological quality of life. And we have a lot of different reasons why we think these symptoms might impact on quality of life, but we don't fully understand what might be the really important drivers for that. And it may well be that that's very individual between patients. But I think what we've talked about already has been very much about whether symptoms are present or absent, and maybe a little bit about how severe they are, but very little work in the past has really thought about the timing of symptoms, apart from thinking about pain with menstruation. And something that we're particularly interested in is actually what happens when your symptoms suddenly worsen or suddenly improve. And so I'm going to hand over to Lydia, who's going to talk to us in much more detail about flares and symptoms associated with pelvic pain.
Thank you. So I'm going to talk about these flares and symptoms. So we know in other conditions that these flares and symptoms have been described. So they've been previously looked at a lot in urological chronic pelvic pain in both men and women. A lot of this work has been done by the Multidisciplinary Approach to Pelvic Pain Consortium in the US, looking at these flares, these worsening of symptoms. And as part of this, they've done a systematic review and meta-analysis that's identified 59 articles looking at flares in urological chronic pelvic pain. But you can see here, even in their conclusions of these studies, they've still stated that it's poorly understood in terms of the manifestation of these flares, the triggers, the treatments, the prevention, and the pathophysiology of these flares. So even in this condition where it has been looked at before, we still don't really understand them. Now, when we think of endometriosis flares, there's very little research that's been done in this area at all. But if you Google endometriosis flares or look on Instagram, you see lots of infographics, people describing their experiences of endometriosis flares. So this is obviously an area which is hugely important to people with endometriosis and is something that they experience on a regular basis. So as part of the TRIP consortium, we wanted to look at this in a little bit more detail. So to do this, we've asked participants to complete a questionnaire asking about their flares. And for the sake of this, we've defined flares as symptoms that are much worse than usual. And we asked about these flares in different lengths. So short flares, so they're flares that last less than an hour. Medium flares, so they're more than an hour, but less than a day. And then long flares, so they're more than a day in length. And for this, we've looked across these different TRIP groups that Katy's described. And for this, obviously, we do not have the controls because they do not have pain, so they don't have flares of symptoms. So looking across these chronic pelvic pain groups, although I will focus on the endometriosis groups. When we look across the cohort, we see 76% of participants report flares of at least one length. So that's a huge proportion of people experiencing these flares. And when we look at how they break down to short, medium and long flares, you can see there's a lot of variety. So some people experience flares of all 3 lengths, some experience flares of that only long flares or only short flares, and every combination in between. When looking at those with endometriosis, we can see up to 2/3 of those with endometriosis experience flares that are medium length, as well as short and long flares. So it's really common in endometriosis specifically. So then we wanted to see what symptoms are changing in flares. So what are the symptoms during flares? And we found that these flares are associated with both painful symptoms and non-painful symptoms. So just to show these a bit more, so these are symptom ratings from 0, no symptoms, to 10, worse symptoms. And I'm just showing the medians here. And you can see we ask about a variety of different symptoms: pain, pressure, and discomfort in your pelvis or bladder is very high scoring in these symptoms. But we also have symptoms such as urgency to open bowels, which is also being reported as quite highly during these flares. So it's just showing that there's more to these flares than just pain symptoms. There's also non-pain symptoms as well. We also asked about the most bothersome symptom across all flare lengths, and for those with endometriosis, that was pain, pressure, or discomfort elsewhere in the pelvis. So not in the bladder, not in the vagina, but in the pelvis. So this is showing there are lots of symptoms associated, but the most bothersome one was that pain. So then we asked them about what they did during a flare, so what they felt made them feel better, or what actions they took during a flare. And we asked about whether they contacted a healthcare provider, asked for medication change, rested, and we found the large majority of participants reported resting during a flare, and a very small number reported contacting a healthcare provider, particularly for the short and medium flares. Although we don't yet know quite why that is, this is something that definitely needs more exploration. Now, triggers. We know that from other studies in urological chronic pelvic pain that sometimes people can identify triggers for these flares. When we asked our cohort, 68.5% could identify triggers for their flares. Now, we asked them for a long list of different things that could potentially be triggers, and I know this is a very, very busy slide with lots of different triggers there, so I'm just going to highlight a couple. So menstrual cycle and vaginal bleed is something that we would traditionally think of as a trigger in endometriosis. We know that endometriosis can be associated with period pain, with dysmenorrhea, so we would expect that to be potentially a trigger for people with endometriosis. What was probably more surprising, less expected, is that people reported stress as being a really big trigger in this cohort for their flares, as well as various other things such as bowel opening and exercise. And this stress being a key trigger is true for both short, medium, and long flares. So it's obviously something that is having a big impact and triggering these flares across all durations. So then we wanted to see what impact do these flares have on your life. So what does it mean to have these flares? Now, more than 60% of participants said flares kept them from doing things they would usually do, some or a lot. More than 80% thought about their symptoms during a flare, some or a lot. And more than 80% said the symptoms bothered them, some or a lot. So this is having a huge impact during the flares on their life. But as well as this, we compared those who experienced flares with those that did not experience any flares. And we found that those who experienced flares had greater anxiety scores, greater depression scores, and worse quality of life, particularly in physical functioning and energy and fatigue. Now, naturally, we can't say a directionality with these. We can only say that there's a sort of comparison, there's difference between them. But what we'd expect is that having these unpredictable flares that are having a huge impact on your life would be causing increased anxiety and worse quality of life, rather than the other way around would be what we would expect. So then we wanted to see how much time is in this flare. So if you're experiencing these flares, how long is that affecting you for? Now, a median across the cohort was 16 hours per month spent in flares. Now, to put that into context, that's more than the waking hours of one day. That's 2 work days or 2 good nights sleep. So this is a huge amount of time every month that these people are reporting experiencing flares. And there's also a significant correlation between the hours per month spent in flare and pain-related helplessness. So this is suggesting that it might be this unpredictability of these flares, perhaps, that's causing people to have this helplessness feeling around pain. So just to summarize what I've said about what we've found so far, 76% of participants experience flares, and these flares range from 1 minute to 4 months, so a huge variety in different durations. They're associated with both pain and non-pain symptoms. 68.5% of participants can identify triggers for these flares, and these are having a huge impact on their lives, both in terms of them thinking about the flares, and also flares stopping them from doing things they'd usually do, and the symptoms of the flares bothering them. And as I said, a median of 16 hours per month was spent in flares. But what we still don't know is what the underlying mechanisms for these flares are. What is there that's happening that's causing these flares? We also don't know what impact predictability has on flares. So if the flares are more or less predictable, does that impact how you experience them? We also don't know where people with endometriosis learn about these flares. Are these conversations that are being had with clinicians? Are these conversations being had in support networks? Where do people get and share this information about flares? And we also don't know if there's any treatments that are already being used or other coping strategies that are being used by people that are effective already for helping alleviate these flares or prevent these flares. So as part of this, we are expanding this to look at this in endometriosis a bit more. So we are asking anyone with endometriosis to please complete and/or share our survey, which is asking in a bit more detail about symptoms of flares and your experiences of flares to try and answer these unanswered questions so far. I'm just going to leave this up, but thank you very much for listening.
Thank you. Thank you. It's super interesting. Katy and Lydia, thank you so much. What incredible numbers. You know, the depression and anxiety influence and association with endometriosis and 16 hours per month is just incredible, you know, especially when you put it into context of when that might be during sleep, during time of recovery, family time. Incredible impact, right?
Yeah, exactly. And I mean, this is only the time spent in flares. So this isn't the time when your symptoms are much worse. It's not saying that the rest of the time you have no symptoms either. So that's the other point. This isn't, your symptoms are much, much worse than usual and really stopping you from doing things you would normally do. So it's a huge amount of time. Yeah.
Absolutely. Absolutely. So guys, don't forget, you can get some questions in the chat. There's some super interesting stuff there. You can do the questions anonymously as well. So please feel free to get your questions in the Q&A, or even perhaps points of interest that you think might be good for facilitating a discussion. But thank you so much, Katy and Lydia, for that. Okay, let's move on to the next talk, the second presentation. Jasmine, it's over to you if you want to share your stuff.
Yeah, bear with me a second. Can we see that okay?
We can indeed. It is in the mode where we can see all of the slides on the left, if that's okay with you.
Oh, I've just put it onto present mode. Is that better now?
We can still see the slides on the left-hand side as if you were editing. That can be fine if you want to go through with that. If not, we can give you a moment just to see if you can share the screen as a full slide.
Fine with that.
Yeah.
I'll go on just because.
We'll go ahead. Brilliant. Thank you.
Yeah, so I'm going to talk about a recent study that we published a couple of months ago, where we looked at people's experiences of looking for help for their endometriosis, either people who have a diagnosis of endometriosis or people who were looking for a diagnosis of endometriosis, to understand that sort of help-seeking pattern and what factors influenced whether people were more or less likely to seek help for that. I'm going to skip over this bit of info about endometriosis itself because we've had a great overview of that. But I want to start by contextualizing what it's like for people with endometriosis or other gynecological painful conditions, just to highlight that when we come to talking about pain, it can be a real gendered health issue, and there's lots of evidence that sort of highlights the impact of sex and gender in how we choose to communicate pain and how that's perceived by the people that we want to seek help from. So just to highlight a couple of examples, as you can see on the slides there, there's evidence that suggests that when women are going to emergency departments or A&E, they're waiting much longer than male counterparts and are less likely to be given effective painkillers than male counterparts. More recent work just from the last year in 2023, finding that people who were listening to women describe painful experiences saw them to be more emotionally dramatized than descriptions given again by male counterparts, with those reports being seen as overstatements or inauthentic or, like I say, dramatized.
I could just jump in there, Jasmine. Sorry, I wanted to make sure you get through as much as possible. We're not seeing the slides move, so I wonder if you might have an opportunity to. So we're still on the first slide, which is exactly how we started. So perhaps we can have another opportunity to share. No problem at all. This is technology. This is what happens.
How many years down the line are we into this?
There you go. I don't think we will ever get the hang of this.
Let me see. Is this Oh, I wonder if it's because of how, there we go. If I change my screen there, is that better? Can you see this now?
Yes, there we go. Perfect. I knew giving you a chance you'd figure it out. Absolutely.
Yeah.
Fantastic. Please continue.
Really good at thinking on my feet when it comes to things like this now. Lots of experience. Sorry about that. Yes, so you should have been seeing this screen here. Just highlighting those issues around communicating pain. I was just coming to the point on this racial bias as well that overlays the gendered bias when it comes to perceiving pain, and that people of Black, minority ethnic backgrounds are perceived to have greater pain tolerance, thicker skin, feel less pain than white patients. And so I guess this is just to make the point that communicating pain, looking for help for pain, is contextualized by the fact that it's a gendered and a racially context issue. So previously, a few years ago, myself and one of my collaborators decided to have a look at, okay, how are people with endometriosis talking about their pain? How can we understand what's going on in these clinical encounters that might be influencing those perceptions of what healthcare providers might be seeing as over-dramatized or exaggerations? And these are just a few examples of what we found in that work, where people were using these really powerful, vivid visualizations of their pain, using these metaphorical expressions that we don't see as dramatized or exaggerated, but are genuinely the way that people feel that pain inside them. You know, it is so severe that these are the only ways that they can find to communicate that pain in a way that makes sense for them, and in a way that elicits the kind of empathy and support that people feel they want and they need when they're having this experience. So really powerful descriptions. And so this is sort of underpinned the next sort of phase of work that we're doing. And so what we've done is we've taken a step back and we've thought, okay, there's these kinds of contextual issues around gender, race, descriptions, verbal descriptions. How is this influencing what people are doing when they try to seek help, or what factors are coming into play when they try to seek help for that? There's a lot of evidence around help seeking and the factors that influence it, but actually we don't have a thoroughly theory-informed understanding of what determines that behavior. And so what we did was take a behavioral psychology model to underpin our approach, to make sure that we had as comprehensive as possible an understanding of the various factors that influence that help-seeking behaviour. And that is through this COM-B model, which identifies the determinants of behaviour through capability, so the C, that is, do I have the physical skills and psychological knowledge to go and seek help? Do I know what to do to get that help? Opportunity, the O, is, are there environmental factors that are helping me to seek help? Is there availability of services, or are there other factors that prevent me from seeking help in my wider environment? And motivation, do I want to seek help? Do I have that motivation, that inner drive to go and seek help? And all of those factors have subdomains within them that capture various other factors that influence a person's ability to engage in a particular behaviour. And so just to skip over some of the other stuff to get through to the actual things that we found, this is what the COM-B model looks like. And it sits in this broader model that we call the behaviour change wheel, which basically helps us to identify what the barriers and facilitators are, and then map them onto key techniques that make it more easy for people to engage in or change a particular target behaviour. And so we can use that to create thoroughly theory-informed, evidence-based interventions to alter that behaviour. And it's this stage 1, 2, and 3 that I'm talking about in this talk here. So what we did a mixed study with interviews with people with a diagnosis of endometriosis, and we did a broader online survey with people who had a diagnosis of endometriosis or were in the process of seeking a diagnosis. And we asked them questions that were framed around that COM-B model to try to pick up on all of those factors driving their experiences of seeking help for their symptoms. And so mapped onto that COM-B model, this is what we found. The first one being that capability, these experiences of repeated dismissal or not being believed by healthcare professionals was leading people to have a disbelief in their own symptoms, to doubt themselves about whether their symptoms were real, were genuine, or were worth seeking help for. People were also feeling exhausted with the physical management of endometriosis, of the pain, but also the psychological advocacy was just so tiring that was stopping them from feeling like they could go and seek help. Motivation was very much informed by, again, those past experiences of healthcare where they were feeling like they weren't believed, they wouldn't be believed going forwards, and so this was leading to this lack of motivation, a loss of motivation to seek help, because they just didn't feel like, if I do, it's not going to be a good idea. I'm not going to get the help and support that I want and need. And then finally, in the opportunity category, again, sort of social issues around stigma, medical misogyny, gaslighting led people to feel like they didn't have the support available within the healthcare system to seek help. But also there were issues around their workplace, line managers not being understanding, not giving them the time off to go to appointments. People reported having surgery and going back to work 1 or 2 weeks earlier than they should have done, because they felt that kind of pressure from the workplace to, be back at work and not recovering. And then the final one within that opportunity was the cost of private healthcare. Most of the participants, if not all of them, felt that private healthcare was sort of the gold standard. That's where you're going to get your fastest diagnosis, your referrals for treatments and so on. But the cost of that was a real barrier. And so just to bring those findings to life, I just thought I'd present a few quotes from people just to demonstrate what I mean by this sort of psychological capability, which is the knowledge of not knowing what to do to seek help, or feeling helpless or exhausted. For this particular person, their pain just became part of their life. They just accepted it, that this is going to be something that I'm constantly going to have to deal with, and I'm not going to get the help to address that. Likewise, that physical capability, that exhaustion, not having the energy to get out of bed or to go out and do social things with friends and family because they were in so much pain and so tired from physically managing the symptoms. In terms of that social opportunity, that was the influence of the wider social circle that influenced their behaviour. So these experiences of being told your pain can't be that bad, it's in your head, maybe you just need to do a bit more exercise, or you're going to outgrow it, that really sort of made people feel oppressed and like they couldn't seek help from their friends and family members because they were going to be met by these kinds of responses. Likewise, that physical opportunity, that issue of private healthcare being unaffordable and out of reach, and then again, jobs not being supportive, so people couldn't get the time off to go to appointments. And then finally, within motivation, this is just to demonstrate Sophie's experience of going through repeated appointments, going through this trial and error approach. Okay, we'll try one thing, that's not going to work, and we'll try something else, that's not going to work. All of this sort of led up to her thinking and feeling that actually the diagnosis process, the treatment process just isn't going to work for me. I don't trust it because it's not a clear pathway for me to go down. Health teams are just trying things without very much evidence or patient input into that care. So what does this mean? This means that we've now got a more thorough theory-informed understanding of what helps people and motivates people to seek help, and what might prevent them, what might act as barriers to seeking that help, and we can use that to develop future interventions going forwards now. Key things being educational, skills-based interventions for health professionals that educate them on endometriosis, and that is the front line, the first people that people with endometriosis are seeing, the GPs, the nurses, who, you know, as much as they've only got 10 minutes in their appointments, I need to be looking out for these kinds of symptoms, these kinds of reports, and recognizing them much sooner. And then other recommendations around how people are responding to those health disclosures, given that it takes a lot of effort for people to talk quite openly about quite sensitive issues, and for that to be dismissed, unacknowledged, you know, undermined, can have a significant impact on people's future engagement with healthcare. So we need some work around how health professionals are responding to those disclosures, targeting long waiting lists, and targeting those issues of mistrust and dismissal that people are experiencing. I appreciate that was a whistle-stop tour of those findings. So I want to stop there and thank you all for listening. And if you want to read more about this work or any other work that we've been doing in this area, there's lots of links on the slide there for people to have a read more.
Amazing, Jasmine. Thank you so much. That's really, really interesting. And it's a great way to highlight, you know, opportunities like we're doing today, is discussing the topic and really having an open discussion about what we can do better. And it's really interesting to highlight the sort of social norms around the management of endometriosis and how we need to be more open. And perhaps that's something we can discuss a little bit later today, which is brilliant. So I can see some questions coming in to the chat. Obviously, there's more opportunity for you to do so. Please pop them in, and then towards the end of the session, after Marcelo's presentation, we can have a discussion and we can answer your questions, no problems at all. So finally, if we want to hand over to Marcelo, looking forward to your presentation, if you want to take over.
Yes, okay, I will share my screen.
That's brilliant. We can see that, no problems.
Okay.
Just before we start, Marcelo, we can see the notes version that you've just brought up. I don't know if you want to just take an opportunity just to change that, so we can get a good view of the slides.
Let me see what the problem is.
That's fine. That's fine. Take your time. We know this type of thing happens with technology and sharing screens and stuff.
So the problem. Let me see why you are seeing my notes.
Yeah. I think the most difficult thing about this is that no one can really help. This is something that you'll need to have a look, but please don't feel rushed. Take your time. I wonder if we have an opportunity to bring Melinda into the discussion.
Now you are seeing my notes yet?
No, we're seeing the full screen. We can't see your notes there.
Okay.
So okay.
Now it's okay. Okay, let me start. So I'm pleased to share again our research project, and it is about the psychophysiological impact of a mindfulness-based intervention in women with endometriosis. So I will talk about the cognitive and affective mechanism of mindfulness effect on pain and mental health. I'm also try to put it in a broader perspective of endometriosis management. Now I have problem to pass this slide. I'm sorry.
It's fine.
Let me see what happened here.
Yeah, that's fine.
Oh,
there we go. Seems to be moving forward now. Brilliant.
So the endometriosis field is still dominated by HLS-based therapy. It is an approach focused on the characteristics of the lesion as the main contributor to pain. So according to this approach, treatment is restricted to targeting the many peripheral pathophysiological paths that can lead to nociceptor activation. So as we see in this simplified, not so simplified, but directed acyclic graph, the paths are complex and challenging to block, even consider just the part of the factors that may influence endometriosis pain. Consequently, the results of such an approach are limited. So 1/4 to 1/3 do not respond satisfactorily to hormonal treatment. And the anti-inflammatory drugs have not demonstrated benefits, although they have not been so well studied yet. And only 30 to 4% improve with surgical treatment. And there is a high rate of pain recurrence when patients are submitted to this procedure. So as you can notice in this scheme, there are several possibilities for the nociceptive stimulus to persist, many with we consider influence other than only the periphery. So as in other fields like psychiatry, etiology-based therapy is recognized today as inadequate for dealing with chronic pain. So there is a tendency to move to mechanism-based therapy in the pain field, and recently it has been applied to endometriosis, as Professor Katy and Lydia exposed. In this approach, despite individuals being affected by the same condition, they may present particular mechanism that can contribute to pain. There is a particular phenotype. So we can think about phenotype in one domain of human functioning, such as classifying individuals according to which alteration of the nociceptive system is involved in the patient's pain. Or we can think about phenotype as a broad set of factors from multiple domains present in a given individual that can influence pain. So for example, two women with endometriosis-related pain, even having similar lesion characteristics, may have different mechanisms leading to pain, and by extension need different treatment plan. The reasoning behind the mechanism-based therapy is simple and plausible. So recognize such a broad set of influential factors and knowing what combination of therapeutic approach can change them will lead to better outcomes. For sure, the theory is much easier than practice. Uncovering how to assess and treat such a comprehensive perspective is quite a challenge. So following this reasoning, to improve precision, you must know how interventions change outcomes in the context of living with endometriosis. And one contribution of our research project is understanding how a brief mindfulness-based intervention changes pain and quality of life mental health in the context of living with endometriosis. So our sample was composed of women with deep endometriosis who did not respond to medication. We compared the brief mindfulness intervention plus standard care with just standard care as a control group. So the main component of the mindfulness-based intervention, like other traditional mindfulness-based intervention, were meditation practice, inquiry, and education. So in brief, during meditation, participants are taught to regulate attention on the flux of body sensations, even when the sensations are unpleasant. So note distraction, perceiving thoughts as thoughts, let go distraction with patience and tranquility, and sustain an intention to stay aware, to stay in the present. During the inquiry, the participants shared what they perceived during the meditation. And education was delivered about a set of themes like reconceptualized pain modulation, mindfulness attitudes, stress response, and the interaction between thoughts, emotions, body sensations, and the role in stress, pain, and well-being. So to identify potential processes involved in the mindfulness effect, we consider that mindfulness refines cognitive and emotional regulation, which is relevant to changing pain and mental health. So we take into account associations found in previous studies to select the constructs of pain catastrophizing and positive and negative effect as potential mediators. So pain catastrophizing is the tendency to magnify the freight value of pain, that to the inability to inhibit the pain-related thoughts and feelings of helplessness. And the positive effect is, for example, constituted by feelings like being inspired, enthusiastic, and determined. Negative effect is composed of feelings like being nervous, afraid, and upset. So the relevance of these constructs as mediators is demonstrated, for example, by studies showing that pain catastrophizing at baseline predicts endometriosis pain severity after 1 year of follow-up, and is associated with pain threshold of heat and cold in women with chronic pelvic pain, including those with diagnosis of endometriosis. Also, qualitative studies have pointed out that the experience of dealing with endometriosis as expected is marked for negative effect and blunted positive effect, which potentially we know that can influence pain and quality of life. So to investigate that, we developed 3 main models to understand which pattern of association between these mediators better explain the mindfulness effect on pain intensity, pain unpleasantness, and mental health. So the first model assessed the independent effect of pain catastrophizing and effect. The second model conserved the independent effect of pain catastrophizing on pain, but also assessed 2 serial chains: the change in pain catastrophizing and effect, also the change in pain catastrophizing and pain itself to explain the mindfulness effect on mental health. And in the last model, just the serial change in pain catastrophizing and effect is used to explain the intervention effect on mental health and pain. So our results show that the brief mindfulness-based intervention, as expected, improves the potential mediators, pain catastrophizing, positive and negative effect compared to control. Comparing the fit index of the models and the residual of each path, we found that the change in pain is better explained by improvement just in pain catastrophizing. But the change in mental health can be adequately explained by multiple paths via serial change in pain catastrophizing and positive effect, as well as serial change in pain catastrophizing and pain itself. Additionally, the mindfulness effect on mental health was achieved by improvement in positive and negative effect, independent of pain catastrophizing, and importantly, independent of change in pain. So our interpretation is that improvement in attentional regulation and cognitive inhibitory control induced by meditation training may have facilitated the pain catastrophizing reduction. So the diffusion from cognitive content, that is the ability to perceive thoughts as thoughts related and unrelated to pain, that feeds negative emotions and prevents pleasant sensations, can explain the pattern of affect improvement independent and secondary of pain catastrophizing reduction. So our results also suggest that mindfulness does not improve endometriosis pain through independent change in affect, positive or negative. That is, regulation of pain catastrophizing is essential for such an outcome. And mindfulness can improve mental health by pathways including, but not limited to, pain reduction, highlighting the independent potential of the improvement in affect to restore mental health. So it was a brief interpretation of this finding. Surely there are details and limitations that you can and should read in the paper. So you can assess the details of this study and other contribution of our research project in these papers, in this set of papers. Maybe you might want to take a picture of the screen. And I would like to thank the Marco Aurelio, Olga Lucia, with whom I carry out this project. And thank you to those who attended to the webinar for your attention and the interest in the theme. And
thank you, Marcelo. Thank you very much for that. Really, really interesting talk and in depth as well. And it was interesting to see the results at the end. So we have just under 10 minutes for some questions. So hopefully we're going to fly through. If anybody does have any additional questions, please pop them into the question and answer feature. We do have a couple from T-Lin who has popped a few in. The first one I think has been answered by Katy in the chat. So thank you so much, Katy, for that. If everybody wants to pop their cameras back on, if they're able to, unless I could just sit here on my own, just minding my own business. I know you're all there. You're all hiding. I know you're there somewhere. But thank you so much for the presentations and Katy for answering that first one. So T-Lin's second one, which I think might be aimed at Jasmine. I don't know if you've had an opportunity to see this in the chat, but it says, where would fear best fit in the change of behavior model when considering knowledge, ignorance, and fear taught by fellow community members? Do you believe that there could be a community-driven threshold level of pain that patients ultimately believe are required before seeking medical help? I think that's a really good question towards your social perceptions of when they feel like they're able to seek help, you know.
Yeah, thank you for the question. For the first part of the question, sorry, I pressed the button. I pressed the button in the Q&A section. It's say that I was going to answer it live, so it's disappeared from my screen. That first question about fear, it's a really strong emotional driver of behaviour, and it fits into that motivation category of the COM-B model. But I think what's really tricky with endometriosis pain is that there is so much overlap between the knowledge and the prior experiences and expectations that drive the behaviour. So it can be quite difficult to disentangle all of those things and categorise them in the COM-B model. I think they all play a role in driving the behaviour together. But if we were talking about fear as a standalone factor, it would fit into that motivation category, but recognising that fear stems from those prior experiences and reinforces future behaviour. In terms of the second part of that question about that sort of community-driven level of pain that people might be feeling they're expected to have before they should go and seek help, I can see in the descriptions that we've seen in our research that I showed in the early part of that talk, those really powerful, strong, vivid descriptions. I could see how that can lead to people making those social comparisons against one another and maybe seeing, okay, my pain doesn't quite feel like that, or I wouldn't choose to describe it in that way. And so that might lead to people feeling that their pain experience is less legitimate, less worthy of seeking help, or if they're not talking about it in that way. But I think the message here is that we really need emphasis on the fact that pain is so unique to all individuals that it is not possible to make that comparison across from one person to another, and people will choose different verbal expressions to talk about their pain. I think the most important element of that is that if pain is disruptive to your life in any way, then that is legitimate on its own, regardless of how that compares to what other people say about their pain or how they experience that. And so I think there's work to do to sort of remove that comparison and help people to feel supported, to look for help, look for support, regardless of how it feels for them personally.
Mm-hmm. Mm-hmm. And is it this addressing societal norms around women's health and the fact that it is individualized, and there's some very, very similar, attributes towards chronic pain in general, in that they don't feel believed, they don't feel like they need the care, or perhaps they don't feel like they're going to be able to get the care. In what ways can we do that, Jasmine? You kind of touched on there, but I want to mention what Lydia showed about social media. What role does perhaps social media have on developing people's understanding that it's personalized? You don't need to meet any threshold to be able to go and access care, and possibly more importantly, explaining what care is there, and how they can go about navigating that, and how to gain a support network. What role does social media, and perhaps are there other things that need to be done?
That's a big question.
Big question.
I'm not gonna. I maybe leave Lydia to talk more on the social media side of it, if she prefer. I mean, I'm happy to comment on it, but I think one of the things that I would like to say on that is that I think a lot of this stems back to what we're taught in schools, what is happening from a very, very early ages in schools when it comes to reproductive education, sexual health education. There is not a lot there even now on supporting young girls, young adults, and then women as they grow up, to understand their bodies, to understand what is normal and what is not normal, and how to navigate those conversations in their wider social sphere, whether it's friends, families, and further down the line, whether it's with healthcare professionals. So I think this comes right back to that early learning and socialization. I think social media has an amazing role to play, but I haven't explored that in very much depth myself. I feel like Lydia might have more to say on that. And if not, I'm sorry for throwing you.
No, it's fine. So I think what you said is exactly right. I think it's broader than, I think social media can give you a snapshot of it. And I mean, for this, I've just done a quick search of seeing how much things come up. So there's about 26,000 posts on Instagram with the hashtag EndoFlare. So it's showing that it's widely used, but we need more work to drill down on what is being said on social media. And I think we all know that social media is full of some really useful information, some really useful support networks, but it's also full with a lot of misinformation. And what role each of those play, and the benefits and cons to this is much, much broader. You could have a whole webinar on it, I think. But yeah, so I think we don't really know particularly what role social media has, and it does have some amazing roles, and some people report the sort of networks that you can find on social media as being really validating, really supportive, and have really great experiences on social media. So I think it does have a really important role to play, but I think we all have to acknowledge that there is a lot of information on social media that isn't scientifically backed. That doesn't mean it's not necessarily true. It might be true, and individuals' experiences are their experiences, but I think we take it out, sometimes it can be taken out too broadly, and there's not necessarily scientific evidence that these things work, and we really need that to be able to say what is facts and what isn't.
I think it's a fair reflection of how society sees the problem. People are quite open on social media, and if they are, that it's a good avenue if you can utilize it. But you're absolutely right. And in which ways can we do this, and which way is the most appropriate to harness something as powerful as social media to change perceptions of this type of thing, which we can see would be a huge benefit. Guys, I've got loads of questions. I've got loads of questions here, which I wish we had more time to ask, but unfortunately we don't by the looks of the time. So perhaps maybe we can organize another one in the future if you guys are involved with research in this area. Perhaps you can come along to present that again. That would be fantastic. But again, like the other talks and webinars that we've had on this topic, lots of questions coming through and lots of discussion. So really, really appreciate that. And that's obviously for you guys for giving such fruitful talks, and your work around this topic being so fruitful and engaging and getting people talking, which is fantastic. So again, thank you so much for your time. We are going to have to end it there. Which I appreciate is probably a lot shorter than we wanted to do. But it was a really fantastic webinar, really interesting topics, and I think everyone has found that super valuable. So as I mentioned earlier, this webinar is recorded, so everyone will have access to the recording of the session via YouTube or via the EFIC Academy web platform. So you can find a link, hopefully, in an email that will come to you after this as well. again, if you don't find the link, please go to the website. That will you'll be able to find it there. So again, thank you so much to Katy, Lydia, Marcelo, and Jasmine for your time today. Really appreciate it. Have a fantastic rest of your week, and we'll see you next time.